Hello, everyone. Welcome to today's webinar on primary biliary cholangitis, PBC. My name is Ivette Williams, PBC patient advocate and regional leader of the Illinois PBC support group as an active member of the PBCers organization and a strong supporter of ALF since 1999. I'm considered now an old PBCer and I still have my own liver. Donna Boll was supposed to co-moderate this with me today, so I will read her part. Donna Boll, she's a PBC patient advocate and moderator of the ALF PBC support group. Many of you know, she's awesome. And she's had PBC for 20 years and received a liver transplant 15 years ago. And I have the pleasure of sitting down with world-renowned autoimmune liver specialist, liver disease clinician and researcher, Dr. Gideon Hirschfield, to ask him the questions you need the answers to. Dr. Hirschfield is a physician scientist currently based in Toronto with a dedicated autoimmune liver disease practice. He has an interest in developing new therapies for patients living with autoimmune liver diseases, including in particular PBC, PSC, and AIH. This interest has arisen from a variety of research opportunities he has been involved in and includes translational science, research, clinical registry studies, and clinical trials. His hope is that his contribution to larger team efforts ultimately translate into new treatments for patients that make them feel better, function better, and live longer. Dr. Hirschfield, thank you for sitting down with us today. We asked our fellow PBC patients what they would want to know about PBC, and they submitted their questions. The first question, everything you want to know about PBC with Dr. Gideon Hirschfield. The first question is, what is the basic physiology of PBC?
So thank you, Ivette. Just to make sure you can all hear me okay, because technology seems to be challenging today, which is why my webcam is in quarantine, it would appear. So yeah, that's right. I'm a liver doctor. I'm based in Toronto, and we do have a very significant interest in patients with PBC. And I think the first question is very important. What kind of disease is PBC, and what does it mean when you have it? So it's an autoimmune liver disease, and in particular, it's a disease with two components where your immune system attacks the small bile ducts in your liver. And when it does that, it damages those bile ducts. And in damaging those bile ducts, that leads to secondary damage because the bile inside those bile ducts leaks out. And that bile is very detergent and very inflammatory and causes a lot of scarring. So we think the disease arises because of a mixture of genes and environment, that your genes predispose you to autoimmune disease. The environment predisposes you to the autoimmune disease being in your small bile ducts. And then as the disease progresses, what we see is the immune system attacking the small bile ducts withering, being under a fire, having small holes punched into them essentially, and not functioning well, and leading to the symptoms, signs, and consequences of PBC.
Thank you. Now, why do PBC and autoimmune hepatitis, AIH, overlap?
Well, that's an even more complicated question, because I think what you've really got to think about for these diseases is we don't really know the cause of any of these autoimmune diseases. They're not like a viral infection, you know, such as COVID or hepatitis B. You've either got it or you haven't. They are diseases that we diagnose by exclusion. We make sure there's nothing else going on. Now, both PBC and autoimmune hepatitis are autoimmune liver diseases. And in both diseases, there is an attack on the liver from the immune system. However, when you look down the microscope, that attack can look quite similar whether you see it in PBC, the disease we're talking about today, autoimmune hepatitis, or in the other autoimmune liver disease, primary sclerosing cholangitis. So in fact, none of the features that we see in autoimmune liver disease are actually specific to one disease. It's more that most features fit for a patient with PBC, and then that's why we call them PBC. And in other patients, most features look like autoimmune hepatitis, and they respond to steroids, and that's why we call it autoimmune hepatitis. But in some patients, what we see is overlapping features. We actually see the picture looking a little bit blurred. And so clinicians are left with saying, well, I think you've got PBC, but there's a bit more inflammation than I expected, and it looks a bit like autoimmune hepatitis. What I would say is that there's a lot of controversy in the sort of medical textbooks about this. I'm certainly on the conservative side of the equation, and I think it's very rare to find true autoimmune hepatitis with patients with PBC. And what I would say is that for the large part, if you've got a lot of inflammation, it's because your PBC is quite aggressive. And that nowadays, what we really focus on is treating your PBC as well as possible. And I think we'll see less and less people who are called overlap as we treat more and more patients with urso, more and more patients with obeticholic acid, and other treatments either in trials or off-label drugs. And as we treat the PBC better, I actually think this sort of conundrum of so-called overlap will become less frequent.
Okay. Now, would you consider that two separate liver diseases, or is it still one? It's PBC with the...
Well, that's where it gets very complicated. So there are clearly patients who've had PBC for a long time who then develop what looks like autoimmune hepatitis. Mm-hmm. So that should be called what we would use the term as a sequential overlap. And as you say, they've just got two diseases. You know, they've had PBC for 10 years, well controlled, and then they get autoimmune hepatitis. And if you think logically, that wouldn't surprise you, because you might live with PBC, and then one day your family doctor might say to you, oh, you've developed celiac disease, or you've developed thyroid disease. And you wouldn't say, oh, that's ridiculous, it's another autoimmune disease. Where we get the confusion is where people try and make the diagnosis at the very beginning. So when you first present to your doctor, and the doctor says, oh, I don't know what's going on. And my advice there is to treat the dominant process. So usually that means treat the PBC and wait. And actually, we're doing a nice piece of work at the moment showing that if you do treat the PBC with urso, then many of those features of so-called autoimmune hepatitis are not there a year later. So it comes back to my point, we don't have a single test for a disease. PBC is closest of all the autoimmune diseases because we have the anti-mitochondrial antibody test, but even that's not perfect. So my advice is usually to not rush, treat what you see as the dominant process, and think very hard before you make two diagnoses. And the reason for that is not because I wouldn't want patients to get good treatment, but nobody would like to be given steroids by mistake. Particularly women with PBC whose bones could be thin anyway. The last thing you want is steroids for 20 years when you didn't need them. And then, you know, they didn't help you, but you're left with osteoporosis. So we take a much more conservative approach. We don't rush. We treat the PBC as aggressively as it needs to be treated, and we keep an open mind. And then I'd say, look, if you really think that there might be an overlap with autoimmune hepatitis, you're going to have to, I'm afraid, have a liver biopsy. And it's more complicated than just having a liver biopsy. It's a bit like, I think you mentioned you live in Chicago, you know, best art museum in the world. You know, unless you're going to get the people in Washington telling me otherwise, or New York, okay? But when you look at a liver biopsy, it's a lot about how experienced the person is at looking at it. You know, and so when we do a liver biopsy, we really make sure it's looked at by someone who knows a lot about PBC and knows how to balance what they see and really guide the patient and the clinician carefully. Because it's easy to prescribe in medicine, but that doesn't always mean another tablet's what you need.
Definitely. Thank you so much. Now, what causes liver pain, and is it real?
Oh, very good question.
Oh, I'm sorry.
That's a very good question. Did you hear me all right?
Oh, wait, I guess, yes. That's what I had next on mine. I'm sorry. Okay.
So it's true that our patients with PBC, although they've got small bile duct inflammation, do have a dull ache. About a third of them will have this dull ache, and it's not the sort of ache that would take you to ER, but it's real. Okay, I don't know exactly why that occurs, but I think what happens is that when your bile ducts are slightly inflamed, the liver cells and the bile ducts aren't working perfectly. They're working well, but not perfectly. The liver is slightly enlarged. So traditionally, you can't always pick this up by examination, but if a patient has bile duct disease, including PBC, the liver is ever so slightly bigger. And I think that that subtle increase in size, we call it hepatomegaly, contributes to that pain. It's safe to treat that pain, and some people use a bit of acetaminophen, Tylenol, but it's not usually a pain that needs any specific intervention. And certainly there aren't any operations or surgical procedures that will help. But I'd agree with your patients, it's a real pain, and it adds to that sort of chronic quality of life burden where there's that low level of symptoms all the time.
Thank you. Next slide. Okay. Should everyone see a hepatologist?
Great question. Well, I can't answer that because, North America is an enormous place. And wherever people live, there will be people with PBC. And what you want is that care that fits for you. So most of our patients should see at least a gastroenterologist. And definitely some of our patients should see a hepatologist. And some of those should be hepatologists with a special interest in PBC. But it would be unfair for me to say that you have to see a hepatologist, because that isn't actually how it works. Not everyone lives near a hepatologist. That isn't, the reality. And for many patients, they'll get excellent care from a good gastroenterologist who'll make a confident diagnosis and give them treatment, and they'll respond well. So we're actually working on sort of like a 5 steps to PBC, where we're really going to encourage what we've worked on is like the minimal information that we need to teach a gastroenterologist or a primary care doctor. And that really says that if you've made a confident diagnosis and then you know what to do, then you treat with urso, then you know what to look for to make sure whether someone's responding or not. And what we hope that means is that it's okay to stay with the physician if everything's working, but we identify the flags that say you should be moved to a bigger center. And we're actually working on a little tool, we've called it the ABBA tool, ABA, to see whether or not we can make a very simple three-pronged tool that looks at your age, your bilirubin, and your alkaline phosphatase, and just says, okay, you're probably, I don't want to say normal, but you're average. You don't need more than you don't need anything more than you're getting at the moment, or things look like you might need some specialist input at least once, and it would prompt the primary care, the gastroenterologist to say, you know what, maybe I should phone, email, refer to a specialist. And I suppose on those more optimistic moments at the moment, when one is sort of trying to get around your head about the pandemic, one of the more optimistic things I think about is maybe all of this technology, remote medicine, Zooms, webinars, telephone consults, will mean that patients with rare disease can actually connect with experts wherever they live, at least in the US and in Canada within their own province or state. Because really the barriers have been broken down, haven't they? I can look after a patient, any patient in Ontario. It's a pretty big place. I can phone them or I can see them by webcam. They can get their blood test done locally, and I hopefully can give them a lot of good advice without them having to travel 6 hours to see me. So maybe that'll be one of the upsides as things sort of settle down, and that will really help patients with rare disease, I think, because we're not asking you to move, but you're also saying, well, there's no reason why I shouldn't have good care.
Right. I'm sorry, what was the other criteria? You said 3-pronged tool. It was the bilirubin.
So we're going to call it we haven't published it yet, but ABA, age, bilirubin, and alkaline phosphatase.
Okay.
We're not saying that, you know, age is discriminatory, but the truth is that if you're diagnosed with PBC under the age of 50, that often that PBC is a little bit more complicated and often needs a little bit more treatment. That isn't to say that we're not treating everybody regardless of age and their individual circumstances. But if you were thinking about how you'd make it the best for as many people with PBC, a rare disease where you're trying to educate, you know, it's one of 20,000 diseases that a primary care doctor or a gastroenterologist looks after, it is a pretty good flag actually that if you're diagnosed before the age of 50, to really make sure you've had things spot on.
Oh, great. Thank you so much. Okay, next slide. Should everyone with PBC consider a live donor, and when?
Okay, very good question. So look, the majority of our patients won't need to have a transplant. That's the good news. The goal of our treatment is to pick people up early, treat them well, make sure they go through the steps of treatment. They start with ursodeoxycholic acid. They have their treatment response at 6 to 12 months, usually 12 months. If they're not a responder, that they're considered to have obeticholic acid, which is the other licensed therapy in North America for patients who either don't respond well enough to urso or are intolerant of urso. And if OCA is not enough, and it often is enough, that there are other drugs or trials that they're considered for. Now, in a small proportion of patients, their liver will continue to be damaged, and at some point, they may need to be considered for a liver transplant. That is true. Mm-hmm. And when that happens, they'll go to their transplant center. And absolutely, many transplant centers circumvent the difficulty of finding deceased donors by offering live donation. But you can't consider that until you're on the list. But yes, when you're on the list, we all live in the real world. There aren't enough donors. The system is imperfect. The system is set up to try and look after as many people, and it doesn't necessarily account for every disease in the same way. And so live donation has been a lifesaver for many patients with autoimmune liver disease, PBC, PSC, autoimmune hepatitis, that has really made a huge difference. And it is something that some of our patients consider and very successfully go ahead with. But you don't want to worry about it until you need a transplant, because we don't go early. This is not a race that you want to start early. No one wants a liver transplant until they need a liver transplant. It's a big operation. Right. And really what we want is everyone with PBC getting such good treatment that we'll see less and less people having a transplant.
Okay, great. Now, what percentage of transplant patients would you say have PBC return?
Well, that's a good question as well. I mean, broadly speaking, I'd say that PBC returns in quite a lot of patients who've had a liver transplant, but it's only a minority where it's troublesome. And that minority tend to be the patients who started the journey young. So they have their transplant young, they've got longer to live with their transplant. And so the consequence of PBC, which is normally a slow disease, even in a transplant patient, still become of significance. So I try not to worry too much about PBC recurrence. It's real, it occasionally is impactful, but actually of all the recurrent diseases that you get after a liver transplant, it's the one that's probably least worrying for the patient. The important message is, over years, we've done enough research to now say that everybody who has a transplant for PBC should go back onto ursodeoxycholic acid when they've had that transplant. And that makes a really big difference. That has been something that's really helpful to our patients, reduces recurrence, and reduces the impact of recurrence. So very simple, because most patients tolerate urso, and very helpful.
Great, thank you. Now, for over-the-counter medications, vitamins, and supplements, are they dangerous or not for us with PBC?
So good question. Look, most patients with PBC should lead normal lives. Most patients with PBC, we're trying to avoid them ever getting cirrhosis. And what that means is that for most patients with PBC, it's safe to take most medicines. You still want to check. If I work backwards, generally speaking, it's not a good idea to take medicines that are not prescribed if you don't know what's in them, unless they're very sort of common vitamins or supplements you buy from, you know, shoppers or, you know, other pharmacy chains. Broadly speaking, when your liver's working, other medicines are perfectly reasonable. So Tylenol is fine. We always try and avoid Advil, but patients with PBC sometimes do need Advil. They have pains, they have arthritis, they've got other injuries. And generally speaking, if you haven't got cirrhosis, occasional Advil is usually fine. Once you have cirrhosis, and that's why patients with PBC are never discharged, it's why patients with PBC are followed up for life. Once you have cirrhosis, then of course we are more careful with Advil, and we're also just generally more careful with any medicine which we start, just to make sure that it's safe. But common drugs that are perfectly safe for patients with PBC to take include statins, which are very safe, and there's no reason why you can't take one. Tylenol, which is also safe, and other similar medicines that you might need for your blood pressure, for your diabetes, etc. Our goal as hepatologists is to look after your liver so well that you've got time to develop all the other problems. And if they occur, that you can get treated like everybody else. You know, that's actually, I often tell my patients, one of the reasons I don't discharge them is, even if they're well with their PBC, I say, well, look, if something happens, I want to be there to tell your new provider, treat you normally, don't miss out. But sometimes people are so scared, liver disease, I can't prescribe any drugs, you know, that they don't even get the correct treatment for something which is quite simple.
That's true. Okay, great. Thank you. Now, does my initial AMA, the anti-mitochondrial antibodies, ever need to be repeated? Can it be negative and then positive, or vice versa? And why does this happen?
Oh, very good question. These are very difficult questions, aren't they? So, if you're AMA positive, then broadly speaking, you don't ever need to repeat it. Okay. If you're AMA negative, you can still have normal PBC. And just remember, again, I think actually COVID's probably taught us all sorts of things. A test is just a test. Every test is different. Some tests are better than others. Some tests don't work because of technical reasons. Some tests have a bigger range and are more sensitive. So when we see someone who's AMA negative, we repeat the test because we just happen to have a slightly better test. And then sometimes it becomes positive and we have the information we want. So we try not to rely just on one test, and we try and keep things in context. When you treat a patient with PBC who's AMA positive, and you treat them with ursodeoxycholic acid, the amount of AMA in the blood can go down over time. So if someone does happen to repeat your AMA, it can be negative. And we've even seen this in clinical trials where we say, we know the patient's got PBC, I can see the result from 1995, they were AMA positive, I've got the piece of paper, and you repeat the test to get into the clinical trial and it's negative. And that's the reason the clinical trial would still take you, because they'd say, well, we know you've got PBC, it's just that over time, the level has gone down. So it's a very important test, it's a very useful test, but don't think of it just like everything in medicine, nothing is black and white. Mm-hmm. Everything is shades of gray.
Okay, and the number has no relevance, right? The higher the number, it doesn't mean, well, aggressive.
That's a good question as well. So the number doesn't, I look at the number only when it's very low, if that makes sense. Okay. So you don't get more severe PBC because the AMAs are higher titer. So okay. That's no. But look, when I'm about to tell someone that they've got PBC and it's a lifelong disease, mm-hmm. If their blood test is equivocal, you know, it's right on the edge of being positive, and maybe their liver tests are right on the edge of being elevated, then of course I might be a little bit more circumspect. And I might say, you know what, it doesn't all fit. I don't need to give you this label yet. we'll follow you for a bit and repeat the tests. So really, I use it at the bottom end when things are probably, you know, a little bit milder, because I do think, and it's something I mentioned at the beginning, once you make the diagnosis, you want to make a confident diagnosis because it means something to the patient and it has a message for their care forever. So I think getting that diagnosis right at the beginning is so important. It makes all the difference, because if you believe you've got the disease and you understand what you've got, you'll take your medicines. You won't forget. You know, you won't, you know, it's how people live with chronic disease. There's nothing worse than trying to live with something where there's some ifs and buts.
Great, thank you. That was very helpful. Now, does stress make PBC worse?
Well, stress makes everything worse. But, you know, immunologically, sure, people who are run down generally, the immune system does pick it up, but not in a way that we can measure. You know, we know that people get cold sores, people, you know, feel sick after the flu, you know, we know that the immune system is, you know, affected by external factors. I think where stress has most to play in PBC is the symptoms. So PBC is a symptomatic disease whereby, you know, our goal is to treat the disease and stop the disease progression, but at the same time, make the quality of life for our patients as good as possible. And we know that that's very difficult and not always perfect. Patients have fatigue, they have itch, they have dry eyes, they have joint aches, restless legs, etc. And clearly, if you have stress as well, it's much harder to cope with chronic symptoms. You know, if chronic symptoms are wearing you out, then life on top of that can also not be very helpful. So one of the things that we discovered, and one of the reasons we're so keen on groups like the American Liver Foundation, the PBCers, the Canadian PBC Society, the PBC Foundation in the UK, is that when we looked at tiredness in PBC patients, we found that one of the factors associated with most fatigue was social isolation. And again, social isolation is one of these big things that we've suddenly all become aware of in the last 3 months with COVID, that we need our networks. You know, just like you're having this webinar today, that's a form of networking. So tackling social isolation, finding ways to connect with people who understand your disease, usually that's other patients, liver charities, talking about it is actually part of living with a disease and is part of living with a chronic disease. And so I think that's quite important to sort of bear in mind. So broadly, of course, we don't need to be stressed. Broadly, of course, stress has non-specific effects on your health, but largely, I think we're focusing on how that might impact your symptom complex and what you can do as an individual to avoid that, making it harder than it is already, because we aren't going to cure you of PBC. That's not on the agenda yet. Maybe one day, but it's not there yet. And therefore, we have to support you. And we have to remember that doctors are not the best at everything. And those support mechanisms can come from more than just doctors, nurses, physician assistants, nurse practitioners. They can come from your own community, from your family, from your friends, from your patient advocates, etc., etc.
Great, thank you. What's an acceptable range for my alkaline phosphatase to be in?
Okay, another hard question. So look, that's complicated. I'll start from the latest evidence and work backwards. Okay. Broadly, we now say that the lower the better, and the patients who get closest to normal do the best. Okay. The next thing to say is that doesn't mean that everybody has to have a normal alkaline phosphatase to live a full life, but it means that some of our patients we will have a higher target for because maybe they started the disease age 45 rather than aged 85. And for them, we'll have a more aggressive goal to have a normal ELF phos. But largely speaking, I think most clinicians are looking to try and get the patient's ELF phos less than 1.5 times the upper limit normal. So if the normal is about, say, up to 120-ish, increasingly we want it to be less than 200, less than 180. Mm-hmm. So that's broadly what we're looking at. But, you know, the point is you've got to get it proportionate. It means a different thing to different people for all sorts of reasons. But we want to avoid you being in the so-called 200 club, which is 200 and above. And if we can do even better, we can get it to, say, 160, 150 or normal, that's even better.
That's great. Thank you. Now, what is hepatic hydrothorax?
Okay, well, that's an interesting question. So that's not really anything to do with PBC, but that's when you've got very advanced liver disease, cirrhosis, when your liver is struggling and you've started to make ascites. So you've got cirrhosis, the pressure's built up, you might have varices, you might have early jaundice, and you've got fluid retention. Your body thinks that you're in a desert. That's how the body functions in this situation. It retains salt and water, you retain fluid. And then what happens is usually that fluid stays in your belly. You have ascites. But actually what's quite interesting is that there are actually tiny holes in the diaphragm. And in some people, those holes are a teeny bit bigger. And every time you take a breath in, there's a change in pressure. And some people, the fluid accumulates in the lung, in the pleural space, and not in the stomach. And when that happens and it's significant, they get what's known as a hepatic hydrothorax. And because the amount of space in your lung, particularly on the right side, which is where your liver is less, and the fluid usually forms on the right side, not the left side, 1 liter of fluid in your lung can make you very breathless. Whereas in the tummy, you can have tens of liters of fluid because the belly just expands. Whereas the lung doesn't like being squashed. So it's not something that's PBC specific. It's something that only our patients with very advanced liver disease encounter. And it's something where we'd give you diuretics and maybe drain the fluid off.
Okay. Thank you. Now, do I need to know what stage I am and how do I find out?
Good question. So the way I like to look after patients with PBC is 1, make a good diagnosis. 2, always start ursodeoxycholic acid. And then 3 and 4, I do 2 things. I would rather, the first question you ask me is, what is my risk? Okay. Most people are diagnosed young, early, and we want to prevent late stage disease. So if we understand their risk, we'll make sure that they get the best treatment. If urso is enough, that's great. If they need a better cholic acid, then they want to know. That's risk, that's based on blood tests. Stage is also important because it's relevant to your care and how effective drugs are. And most people now are staging patients by blood tests, ultrasound, and a technology called elastography, where we measure liver stiffness, which is a sort of marker of scarring, but not just scarring, but inflammation and bile duct damage. We actually think the best time to do your elastography is actually after you've had a year of ursodeoxycholic acid, when we get a much clearer picture for how much is scarring and how much is sort of bile duct inflammation. And of course, if you've got advanced stage disease, more fibrosis, that's something that you and your doctor needs to know, and as we manage your journey with PBC. But never focus just on stage, because most people are diagnosed early, and the real goal is to identify those who need the best treatment early, because then we got the best chance of that you never become late stage. Now, not everyone has access to elastography, Some clinicians will still use a liver biopsy to stage patients with PBC. That's not what I do. It's not what the guidelines say, but there might be reasons and there might be times for your individual situation and your individual clinician's practice where they look at a liver biopsy to help work out the degree of damage. And if that's the case, then so long as your clinician's explained how and why it's going to help you, then it can be a reasonable test. But it's clearly a test where you want to have dialogue with your clinician.
Okay, great, thank you. Now, should I be concerned with high cholesterol with PBC, and who should take statins?
Okay, so the interesting thing about when you live with bile duct disease is that your cholesterol goes up. And particularly for patients with PBC, they know that was one of the characteristic features is lipid deposits under their eyes.
Mm-hmm.
Now, the good thing about it is that for really quite interesting reasons, the cholesterol that goes up in PBC is not usually bad. It might give you skin deposits, but it's not the sort of cholesterol that causes lipid deposits in your coronary arteries. So broadly speaking, actually, we don't need to treat everybody with PBC who has high cholesterol. So my advice is then linked to more about what do you know about that patient other than their cholesterol and all the different subparticles that your physician can measure. So working backwards, like I said already, it's perfectly safe to take statins. Ezetimibe is another drug to low cholesterol. So patients with PBC can have lipid-lowering therapies. And what we recommend your primary care doctor is to look at you as a whole patient. And if you cross the line because of your family history, maybe you're a smoker and you've not managed to stop, etc., and they say, look, you know what, I think I would normally treat you, then it's perfectly safe to be treated and not to worry, and be treated like everybody else. But it's not because the cholesterol which goes up in PBC is the bad cholesterol. It's just because overall you cross the line as anybody else.
Okay, great, thank you. Now, why do PBC patients seem to generally be vitamin D deficient?
Well, that's a good question. I mean, it's slightly more complicated than that because I think half the world is vitamin D deficient. I mean, if you live in cold Canada, then we're all vitamin D deficient. So vitamin D deficiency is very, very frequent. We don't get enough sunlight.
Mm-hmm.
If you add on top of that, when you've got very mild bile duct disease, it does have an impact, very subtle, but not significantly for most, on fat-soluble vitamins. And so because bone health is so important, most of our patients are women, most of our patients will be postmenopausal, most of our patients don't want a bone fracture. You're less likely to have a bone fracture if your bones are made properly and your bones require calcium and vitamin D. Now, broadly speaking, we give most patients with PBC vitamin D supplements because we think it's in their interest, it's safe, it's effective, you can buy it over the counter. We do measure vitamin D at times, but not necessarily repeatedly, primarily because nearly everyone with PBC should be on vitamin D anyway.
Okay. Now, do lab results tell you if your PBC is progressing? If not, how do we know then?
So that's a good question as well. Look, when you look after a patient with PBC, essentially you do a number of things to work out what's happening to them. One is you talk to them. The second is you look at their blood tests. The third is you might look at their ultrasound occasionally. And the fourth, if you can, you look at their fibroscan, their elastography. And you use all of that information to understand whether the disease is progressing over time. So blood tests can be very helpful in picking up progression, but we increasingly want to pick up progression long before it's irreversible. And blood tests can be quite insensitive with that, and they only pick up when it's progressed too quickly. So techniques like combining blood tests and fibroscans and looking at, spleen size by ultrasound can be better for looking for progression, because then we can do something about it before it's progressed so far that the treatments become too hard. So yes, we use blood tests, but it's in the context of everything else. Within the blood test, we look at alkaline phosphatase, bilirubin, and platelet count in particular. We want to avoid the bilirubin going up, and we want to avoid the platelet going down. And we use the alkaline phosphatase as our flag to say, is urso doing enough, or do you need another drug?
Okay. Now, so many of us have itching and fatigue. Is there really a reason?
Very good question. So two different things really, because I think itch is much more specific to biliary disease. Fatigue is very common in all chronic disease, but is equally prevalent in patients with bile duct inflammation and autoimmune liver disease. So we don't understand why people get itching and fatigue fully. For itching, we believe it's something within the bile that doesn't get excreted properly. So it doesn't have to make you jaundiced, but it's substances within the bile which are irritant to small nerve fibers in your skin, and that causes you to scratch. One of the worst symptoms that anyone can have is bad itch. Fatigue is much more complicated. We believe it's like a combination of effects on the brain and effects on the muscle, plus the combination of other factors such as bad sleep hygiene, social isolation, blood pressure medicines, sleep apnea, that come together to give this complex of fatigue. The reason why it's been so hard to treat either of these symptoms is our lack of complete understanding. But I would say that, broadly speaking, as we treat more people with PBC more proactively, and they go down that sort of line of early diagnosis, early risk stratification, early use of first and second line treatments, I think we are making an impact on symptoms non-specifically. We're much more focused to ask patients about symptoms, and there's some very exciting advances coming for itching in PBC in particular, with new drugs on the horizon which are very much focused on improving itch as well as sometimes improving PBC. Fatigue remains much harder, honestly, much harder. Very important to our patients, can be significant in affecting quality of life, but has proved much more challenging to find the solutions we want. But there is still ongoing work. Simple things like exercise do seem to be still very helpful.
Okay, great. Thank you. Now, when should I have my family members tested for PBC?
Well, I guess in the last 15 minutes, we're coming across all sorts of hard questions, aren't we? Let me say, the way I look at that is, if you have 20 people with PBC, only one of them will have a family history of someone else in their family having PBC. So that is more common than average, but it still means that if you tested 20 people, only one of them would benefit from that. So broadly speaking, we don't recommend everyone gets their family screened. And we tend to take an individual approach where we listen to the story in the family, we look at the severity of the person's PBC, and we look at the age at which they got PBC, and whether or not they already know that someone else has got PBC in the family. So I don't test the majority of my patients' families, but I would test someone who was diagnosed very young. I would test someone whose family who's told me, oh, well, you know what, I did know that my aunt had PBC as well. And then I might say, well, look, maybe we should think about testing particularly your daughters. One of the reasons we don't test is that PBC comes at all sorts of different ages in someone's life. Mm-hmm. So we would be very scared to give non-specific testing, which might reassure falsely. So I tested someone age 30, let's say they're the daughter of someone with PBC age 60, but they weren't going to get their PBC until they were 40. So I wouldn't want to, tell them they haven't got PBC and they'll never get PBC just because I tested them once. So you've got to be quite careful how you implement this, which is why it's usually the exception rather than the rule that I screen family members.
Okay, thank you. Now, does the production of protein correlate to the severity of your illness?
I guess this is referring to like what we call albumin, which is a protein that's circulating in your blood. The liver is a very, very forgiving organ, really quite clever. I'd say it's better than the kidney. Maybe not as important as the heart, but not bad. And actually, it hangs on till the bitter end. And so the liver only starts making protein when you've got really bad liver disease. So very significant with jaundice. So for the majority of our patients, protein production is normal and not to worry about. For a small minority of patients, yes, once your albumin starts to drop, that is a sign that your PBC is more significant and more likely to lead to consequences, including liver failure and liver transplant.
Okay, thank you. And I think we have a few more questions. Okay, why do so many with PBC have joint, foot, and bone pain?
Oh, I don't know. Good question. So I think that we do know that autoimmune diseases are systemic, that as in the whole body is affected. And one of the symptoms that is quite common is aches, arthralgias. I don't think it's only patients with PBC who get this. I think other chronic autoimmune diseases can be the same. And I think that that's probably why, number one. Number two, some of our patients will develop very mild forms of arthritis. Sometimes it's so mild that they go to a rheumatologist and they don't really get very much further forward with them because the rheumatologist says, well, I can't find anything. And we don't then biopsy their joints to prove it, but there is probably some mild inflammation in the joints in a lot of patients with PBC that doesn't damage the joints. It doesn't lead to the sort of arthritis they get with rheumatoid arthritis, but it leads to symptoms. So definitely impactful, not something that is ideal, but we don't know all the causes.
Okay. Now, what's the cause of esophageal varices and how are they treated?
So varices are what I was alluding to, the consequence of portal hypertension. That's the technical term we use. If you think about it, blood goes through the liver and has to get back to the heart. That's the job of the vein draining into the liver and the vein draining out of the liver. The portal vein in, the hepatic vein out. As the liver scars, that route for that blood becomes impaired. And it's a bit like a river that used to have a really nice clear flow, but then starts to get blockages, scar tissue getting in the way. So tree trunks crossing that river. But the water still has to get back. And it's the same for the blood. It has to keep flowing. And so it finds another way back to the heart. So that's when it opens up these shunt vessels. These are vessels that were there when you were developing in your mother's tummy, and they open up to carry blood back to the heart by a different route. And some of those vessels are veins in the esophagus, which are thin-walled, but which drain blood into what's called the azygos vein and drain it back to the heart. The problem with it is they weren't designed to drain lots of blood under high pressure. And so we worry that when varices develop, that they might bleed because they're superficial and they don't have a strong wall. And so to treat those varices, we look for them. That usually means endoscopy. And we can do two things. We can either give a medicine to reduce the pressure inside them, or sometimes we can put elastic bands on them because we can see them and we can see that they look like they're going to go pop. And we don't want that to happen. So we get rid of the varices by using elastic bands to sort of squeeze them and to scar them off.
Okay, and there are no symptoms for that, right?
No, there are no symptoms until you bleed, and and the whole point is to avoid the bleeding. So that's why understanding your stage is relevant to your ongoing care in PBC, because you don't want to have an endoscopy unless you need one. But at the same time, if you do need one, you don't want to miss out. Right. We haven't quite got to the point where we can diagnose them perfectly without having a quick look with an endoscope.
Okay, thank you. Now, can you talk about PBC and COVID-19? What do we know about the number of PBC patients who have contracted COVID?
So that's a good question. We don't know too much, but I think what we do know so far is that it does not look like patients with PBC are more prone to get COVID. So that's good news.
Oh, great.
And it doesn't look like they're more likely to do worse with COVID unless they're very sick already from their liver disease. Now, that's kind of self-explanatory. We would never want anyone with cirrhosis, jaundice, to get sick, because we're already aware that if they get sick, it's quite a stress on their body. And so where I think we've seen problems have been patients who have got advanced liver disease, maybe patients waiting for liver transplants, or patients after liver transplant who are not back to their full health. If they've been unlucky enough to get COVID, then they can run into problems. Actually, around COVID, most of our patients are women. Not all of our patients, but most of our patients are women. And you'll know that COVID, unfortunately, seems to be worse in men. And the risk factors for COVID, which we really need to sort of focus on, you can't change your age, but that's a big risk factor. But your weight, having diabetes, high blood pressure, those things seem much more important than whether you've got pre-existing autoimmune diseases.
Okay, great. Now, one last question. Would you recommend weight loss surgery for someone with PBC with a high BMI?
So that's a very good question. And the answer is quite potentially I might. I think that, you know, the liver is a forgiving organ, but it's not very happy when it's got both PBC and fatty liver, and that it's very hard to lose weight. And some of the best treatments for weight loss and diabetes have been bariatric surgery. So I think if you haven't got cirrhosis, then broadly speaking, weight loss surgery is safe. And even some patients with cirrhosis can still have weight loss surgery. You just want to make sure that the surgeon doing it is in a high volume center where they've got a lot of experience. So again, it's a bit like I was saying, why do I see patients with relatively mild disease? Is to be able to advocate for them and say, you know what, this is a more pressing problem than your PBC. It's no good being overweight, being diabetic, you know, all the risk factors when we know there's a good treatment. And much as it's a blunt treatment, it is the most effective treatment for losing weight is bariatric surgery. And people who've had bariatric surgery live longer. Their diabetes gets better, their weight gets better, their cholesterol, everything. So yes, we don't stop people from having it. We just like to make sure we understand what stage of disease they're at and make sure that they've been well explained the side effects of the treatment.
Okay, and I lied, I'm sorry, one last question. What is the current research being done for PBC?
So there's lots of research going on. I think there's research going from the laboratory up to clinical trials. The laboratory research still works on why do people get this disease? What genes do you need to work on? And I just saw we're part of a big consortium from around the world looking to see if we can find some more genes that associate with PBC. Can we use animal models to map out what happens to PBC, to test new drugs in animals first? And then you fast forward into the research that's going on in clinic, which is around drug trials, new drugs, drugs that affect the PPAR pathway, for example, drugs that help symptoms, the ASBT inhibitors. How do we use existing drugs, obeticholic acid? And then a lot of work around symptoms. How bad are the symptoms? What can we do about the symptoms? And what do patients value? So very active research. We don't want COVID to get in that way. We want our patients to continue to be partners in our research because although it may seem slow to you as an individual, ultimately it makes a big difference in the long term to a disease. And the reason why we've got urso and obeticholic acid is because of research.
Right. Thank you. Well, thank you, Dr. Hirschfield, for your time and expertise. Thank you to all of you for joining us today, and thank you to Intercept Pharmaceuticals for supporting this program. Thank you all.
Thank you and have a good day.
Have a great day. Thank you.
Bye-bye.